Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about a possible complication of perforated corneal ulcer, and that is choroidal detachment, how it happens, what is its pathology, and the possible management. These are the photographs of a patient who has undergone treatment for the corneal ulcer, and there is so much corneal thinning has happened that has led to the corneal perforation, corneal leakage. Incident test was positive, and to manage that one over there, the routine protocol for the corneal ulcer was done. But this patient later on developed choroidal detachment. So let's have a look at that one. These are the ultrasound B-scan photographs of the patient in which the choroidal detachment has occurred following the perforation of the corneal ulcer. Here you can see that in many locations the choroids are touching, which we call kissing choroids. Usually it happens because there is a pressure difference between intraocular and subchoroidal space pressure. The subchoroidal space pressure is 2 to 3 millimeter less than the intraocular pressure, and that's why the choroid remains in apposition with sclera. Number one. Number two, choroid is flexible relative to the sclera. Sclera is composed of proteoglycans and it's rigid. So all these things, when the pressure inside the eye is more than the suprachoroidal space by 2 to 3 millimeter of mercury, it remains opposed, and there continues exudation through the sclera, through the choroidal blood vessels. The fluid keeps on drainage, and so the choroid remains in apposition with the sclera. But when this thing, there is perforation in cornea due to the corneal ulcer, corneal melting, that pressure difference in intraocular and suprachoroidal space is disturbed. Then there is no more that much we called exudation happening, and apart from this, as I mentioned, that the sclera is also a rigid structure, so that in such situation it also retards the drainage. So what happens that the fluid which is being produced get access to the suprachoroidal space, and whatever the fluid over there is get accumulated, and it causes the choroidal detachment. Another photographs of the same patient. Here you can see that choroidal detachment has happened, and they are touching in different locations. Yes, this is another view of the same patient. Here you can see choroidal detachment. So now we come towards the management of such patients, how these patients can be managed. Well, this is an emergency. There is perforation, CTL is positive, aqueous humor is coming outside the eye, and normal anatomy and the structure of the eyeball has been compromised. So what we have to do is we have to close this leakage drainage area. If it is less than 2 or less than 3 millimeter, cyanoacrylate glue can be applied. It is quite effective in closing the ruptured area over there. Also, it strengthens the collagen fibers in the cornea, and it has to some extent the bacteriostatic effects. But if it is more, it's a bigger one over there, then we have to go for the emergency therapeutic penetrating keratoplasty and to secure the eyeball. Our first target, as I always say, is to save the eyeball structure. Once the structure is saved and the anatomy is saved, then everything about the vision can be done. So in such situations, of course, we use the if we use antibiotics, of course, the management of the fortified antibiotics. Also, there is a very good role of the cycloplegics because they help in maintaining the anterior chamber, deepening of the anterior chamber. So This is first thing from the saving the eyeball, that is to close the wound, close the leakage depending upon the size. Now usually such things, serious type of choroidal detachments get healed and get resolved with the passage of time. But if there is so much choroidal detachment that it is not resolving, and then iridocorneal touch is happening over there, the endothelium is getting compromised, all these things happening over there. So in such situations we have to drain the choroidal detachment. But usually in such situations, as I mentioned, small corneal perforations leading to serious type of detachments, with the medical therapy it gets resolved, or maximum we have to go for the corneal transplant to secure the wound, and we continue our other treatments over there. The use of already the eye is in hypotony, so there is no need to go for the aqueous suppressants. And now I show you this photograph that this patient has got its choroidal detachment resolved. This is the, which we can see over there, these are the vitreous fibers over there, which is giving over there other appearance. Otherwise the choroidal detachment has settled down. So this was a very interesting case which I want to discuss with my respected audience, that such type of complications can happen in the management of unresolving corneal ulcers, in which too much necrosis and damage has happened. So we should keep in the back of the mind that there may be choroidal detachment, and B-scan, very gentle B-scan has to be done, and it gives us about the idea about the choroid structure over there, and it can be managed conservatively, surgically, depending upon the situation. As I mentioned, sometimes we also need our help from the retina fellows. If it is there is corneal lenticular touch happening over there and it is not resolving, and kissing choroids are happening over there, so we have to maintain the structure and restore the normal anatomy of the eyeball. So this was a very interesting case which I wanted to discuss with my respected audience. I hope it will be beneficial in their clinical practice. Thank you.